Good evening, everybody. My name is Hannah Boyd Carson. I'm one of the registrars from the East Midlands, and today I'm going to be presenting a paper for our East Midlands ASGBI Journal Club. So today the paper I would like to present was published in the Royal Journal of Emergency Surgery at the start of this year, and it's a network meta-analysis and systematic review comparing the prognosis and outcomes of 4 different treatment strategies for acute left malignant colonic obstruction. The reason for choosing this paper is that it's a common clinical presentation on the emergency general surgical take, which all of us I'm sure will encounter at many times during our careers. Additionally, as we all know, there's multiple options for how to manage malignant colonic obstruction, but I personally hadn't got a clear understanding of which perhaps provided the best outcomes and prognosis for the patients. And what I'm going to do just in this little segment before the Twitter discussion is just go through the paper, highlighting a few key points and a few points perhaps of critique, and then we'll take the discussion back onto Twitter. So first of all, just to say a few definitions. I know some of you who may be watching are having exams coming up, and these are the type of definitions that I understand are expected to be on the tip of your tongue. So just to go through the differences, a systematic review identifies, appraises and synthesises all the evidence that's available that meets its pre-specified eligibility criteria about a specific research question. And people have a specific search strategy that they undertake when performing a systematic review. The meta-analysis is slightly different because the researchers who are performing the meta-analysis actually perform statistical tests and analysis on the combined results of multiple scientific studies. And a network meta-analysis, which is a term that you may not be familiar with, uses the techniques of meta-analysis, but it compares multiple interventions simultaneously by analysing different studies and making different comparisons in the same analysis. So that's why the authors have performed a network meta-analysis in this case, because, as you said, they have looked at multiple interventions for the same problem. So the main interventions that they looked at in this paper were colonic stent, so endoscopic colonic stenting prior to surgery, transanal colorectal tube, which again is not something I have seen very often or at all in this country, but that may be just due to local preferences. Decompressive stoma, so defunctioning stoma as a bridge to surgery, and emergency resection so it's not emergency resection, the bridge to surgery, but emergency resection as alone. Their outcomes were primary or disease-free survival and then 5-year overall survival, while the secondary outcomes were the anastomotic primary join rate, mortality and anastomotic leak rate. So just going through the paper, I thought that the abstract demonstrated what was going on in the paper well. In terms of the methods, again, I thought they were clearly described. I thought their search terms were appropriate. So they used terms such as colorectal cancer, obstruction, colonic stenting, transanal colonic stent, bridge to surgery, and also included emergency surgery in there. The years of their search were 2000 to 2020, so 2020 in the years of their search, which again I felt was appropriate because some people may say that they should have gone back further, but I actually felt that techniques, especially the endoscopic techniques, perhaps from prior to 2000 may not be relevant and applicable to current UK practice. Again, the inclusion criteria was again clearly stated and again I thought relevant. The paper states that the articles that were included had to compare 2 or more treatment strategies for histologically confirmed acute left malignant colonic obstruction. One thing to say about that is perhaps people who present on the acute take in this country may not actually have a histological diagnosis. I know that there's definitely some people we see who present as a first presentation with bowel obstruction due to a cancer. So that's one thing maybe to think about, is they maybe excluded some papers or some numbers of cases that weren't because they didn't have a histological diagnosis. moving on then to the next part of it, so their data extraction was as appropriate, as I would expect for a meta-analysis to be done, and they described how they would be presenting their results in a clear way. Their statistical analysis obviously was a bit complicated. I think performing a network meta-analysis is not something that everybody does every day, as you can understand. But reading through it, it seemed to me as if the main bits were there. They also used the appropriate statistical test for the form of data, so using odds ratio for binary data, so mortality, yes, no, and they also included intention to treat analysis in patients in a non-randomized control trial. So this picture here is obviously taken from the paper, and they included 35 studies looking at colorectal stenting and emergency resection. And just before I go through that, actually, I'll just explain what this diagram is. So this is a network diagram, and basically the lines between the two dots, or circles, it's probably a better word, shows that there was an analysis performed between these two. And the fact that the colorectal stent bridge to surgery and the emergency resection circles are much bigger than these other ones is due to the fact that there was a lot more studies and papers included in these analyses. So as you can see here, 35 studies were included in the analysis for stent versus emergency resection, while only 6, 5, and 4, respectively, were compared for colonic stent versus defunctioning stoma. So that's this one along the middle, so a slightly thicker line, because obviously it's bigger, it's the highest number, and then 5 studies for colonic stent versus transanal tube, and 4 studies for defunctioning stoma versus emergency resection. And then coming on to the statistical analysis, so what they concluded really was that colonic stenting and defunctioning stoma was superior in a statistically significant way than emergency resection. As you can see there, the hazard ratio is greater than 1, which means that they are superior. They also found that defunctioning stoma was superior to colonic stenting, and the hazard ratio, I know a bit confusing, the hazard ratio is less than 1 here, but that's because they were comparing defunctioning stoma to colonic stenting. So whether your hazard ratio is up or down really depends on which way you're comparing. So you always need to read that quite carefully in the description and in the tables to know how to interpret your hazard ratio. They also suggested that defunctioning stoma did increase your hospital stay and cost. I suggest one of the reasons for that would be is patients need stoma training after the operation, whereas the stent, they obviously will have the stent done and usually go home the next day or two. Furthermore, disease-free survival was found to be superior in, again, colonic stenting and defunctioning stoma. I think some of the reasons to discuss about why they got these results. So the paper and the authors concluded that defunctioning or defunctioning in the emergency setting seems to be having a better overall results. I guess some of the reasons for that would be patients who have emergency resections, they're obviously going to be quite poorly, they're potentially going to be obstructed, they may need quicker surgery, which may mean that the lymph node dissection and taking as many lymph nodes as possible may not happen. As they generally, they may be poorly more malnourished, which may lead to longer time in hospital. They may also have a longer recovery following an emergency operation, which therefore may delay chemotherapy post-operatively. So I think that's some of the reasons why the overall survival could be better as well. This paper also suggests that, as we said, the defunctioning or stoma as a bridge to surgery appears to be superior to stenting. Again, difficult to form or say why that may be. Again, difficult to say really, but it's something that we could perhaps bring up in the discussion later on. So yes, so overall I think it's a relatively robust paper. A couple of things really to say would be that it's one of the meta-analysis and systematic review contains the largest number of studies to date. It allows us to compare multiple treatment strategies, and I think that this is relatable to UK practice, as it's a pathology that we encounter frequently. The treatments and the interventions are something that we deal with regularly and have access to. The kind of limitations of the study, I would say, is that they only included 8 randomized controlled trials, and the rest of the studies were non-randomized. And the RCTs were solely based in the colonic stent versus emergency resection. And there was the most, as we saw in the network diagram, there was 35 papers included for that analysis, but much less when comparing other treatments. They also used an intention to treat analysis in the non-randomized control trial group. So what that means is that if a patient was put in the group for, endoscopic stenting, but then they actually went on to have a emergency resection, they were analysed in the colonic stenting group. So that can cause a bit of conflicting interpretation of the results. So I think we're going to pick up on a few discussion points now on Twitter, which will be released as the discussion goes on. These are the hashtags, and we hope that you can join us over on Twitter shortly. Thanks very much.